speaker, Chitra.
Next speaker is a very dynamic young ophthalmologist, consultant cataract, cornea, and refractive services of the Coimbatore branch of the Eye Foundation Group of Hospitals, SHREYAS RAMAMU, and a very versatile surgeon too. And he is going to tell us on phakic IOL challenges in irregular cornea. On to you, SHREYAS.
Good evening, everyone, and thank everyone at ARC AIOS for this opportunity. So today I'll be talking to you all about phakic IOL in essentially keratoconus, although it can, the criteria and the points which I'll mention will be suitable for any irregular cornea as well. So when do we think of phakic IOL? It has become a very important tool in the armamentarium of the various techniques that we have to improve vision in patients with keratoconus. So we essentially use it in stable keratoconic patients who are either stabilized by age or are already previously cross-linked and a sufficient time period has elapsed. One most important point, take-home point from this entire talk would be good spectacle corrected visual acuity. If the patient has good spectacle corrected visual acuity, everything else becomes secondary, because that is essentially what the patient is going to achieve with the phakic IOL as well. We initially were doing it primarily for centered cones, started trying it for decentered cones, and I'll talk a little bit more about it in the analysis which we did of our own cases. So in cases where you've done cross-linking, wait for stable refraction and stable topography for at least 6 to 12 months. This is not just for stabilization of the keratoconus itself, but as we all know, a certain degree of patients with cross-linking can develop a little bit of haze, scarring, and progressive flattening. So it may take a little longer for the refraction to stabilize in those subset of patients. And only once you've waited for at least a minimum period of 6 to 12 months can you take these patients up for phakic IOL. So where does it fit into the entire armamentarium? Now, once you have a progressive keratoconus after you do a cross-linking, or even before you do it, if it's a centered cone with good spectacle corrected visual acuity, you could do just a plain CXL and then later do a toric phakic IOL. If it is an eccentric cone, or more importantly, a poorer best spectacle corrected visual acuity, and the patient is not advanced enough that they will go in only for a Rosquet or a scleral lens, you could try an Intax and improve their best spectacle corrected visual acuity. And after the ICRS, then go ahead and treat the residual error with a phakic IOL. This is one such example of a patient with, where the other eye is just a form first, is almost a very low refractive error with very good best spectacle corrected visual acuity. And this is the other eye. Now, this is not uncommon in keratoconic patients where they have asymmetric keratoconus. And in these patients, although they have good best spectacle corrected visual acuity, they are unable to wear spectacles because of the high degree of anisometropia. And these are ideal candidates for choosing for phakic IOL, and they are really very, very happy. As your initial cases, these are good cases to select from. Subsequently, you may have cases like this where the spectacle corrected visual acuity itself is poor. The patient definitely has a higher degree of eye asymmetry. In these cases, you could do an ICRS procedure. And after the ICRS procedure, you see, while the refractive error has changed completely, the cylinder has even increased, but from 624, the BCVA has improved to 6.9. So now this refractive error can be rehabilitated with phakic IOL. As a phakic IOL in a post-intracorneal ring segment eye is nothing very different from our regular corneas. Just suffice to say that these edge reflections might make it a little difficult for you to visualize when you're tucking in the foot plates of the phakic IOL. And that is just one thing you have to keep in mind while you're doing these cases. Otherwise, it's pretty routine and pretty straightforward, and you should have no challenges whatsoever. The problem of phakic IOL in keratoconus, something which we can face unique to keratoconus, is essentially because we have a falsely high central anterior chamber depth. Now, as we all know, we just rely on two variables, the anterior chamber depth and the white to white, for predicting the postoperative vault of our phakic IOLs. But because of the falsely high ACD and the altered ratio of the central ACD to the peripheral ACD in keratoconic patients compared to normal patients, this is where you may end up with a surprisingly altered vault as compared to normal patients. So while in normal patients, most of our patients would fall below the 3.2 and AC depth, most keratoconic patients end up having the higher ranges of AC depth. And as you can see here, for a similar white to white, just because of a higher central anterior chamber depth, the phakic IOL size can vary as high as 1 millimeter. And this can cause a significant difference. So these are just examples where you have almost this exact same measurement of white to white, but with completely different voids. And again, the patients with almost the same void, but a patient with a very open peripheral anterior chamber angle, but a patient with a more crowded peripheral anterior chamber angle. All this showing that these variations can come in keratoconus patients. In certain extreme situations, you can have a high void, where in this particular situation, where despite repeated attempts, the optic was tending to capture, was raising above the pupil. And this is not very common, but this can happen in odd situations. And in these cases, you'll do well to explant it and put in a smaller sized phakic IOL. So the caveat that I want to convey here is, because of the falsely high ACD, especially with patients with a very high keratometry in excess of 60-65, you would choose one size smaller than what you would choose for your regular patients. And this has worked out very well for us ever since we made this adjustment. These kind of surprises of a very high vault is no longer there once we started choosing one size smaller. Very high astigmatism, you may need customized lenses. And of course, possibility of residual error has to be explained to these patients. Definitely avoid patients who are very comfortable with contact lens, because they would expect the same kind of visual acuity as they had with their contact lens. Again, patients with poor best spectacle corrected visual acuity, as I earlier mentioned, tend to have a higher degree of coma, higher amount of higher order aberrations, which cannot be corrected with the phakic IOL, and they would not be happy, as they were probably not happy with the quality of vision with their glasses. Again, if it's a very advanced cone and you've gone ahead with a DALK, again, these patients post-DALK, since we are less concerned about the endothelium in these post-DALK patients, and they can actually safely undergo a phakic IOL procedure after a DALK as well. And these patients tend to do extremely well. So I'll run you through a quick study that we did of our cases of 126 eyes, which is a fairly reasonably sized cohort when we are talking about phakic IOLs only in keratoconus. We used both toric ICL and IPCL. They were all either age stabilized keratoconus or post cross-linking. And we also had 12 cases which were post intracorneal ring segments, and the minimum follow-up period post phakic IOL implantation was 1 year. As you can see here, the mean age was a little higher than what you would expect for our regular refractive population or regular cross-linking population. It's around 30 because we waited for stabilization of the keratoconus before we went ahead. Fairly high cylinder than what you would expect in a normal population, and a higher degree of IS asymmetry as well. What was gratifying was these patients, 80% of them were within plus or minus 0.5 diopter, 90% within plus or minus 1 diopter of spherical equivalent of intended target. Now, while these may not be extremely impressive when you're talking about a regular excimer ablation or SMILE, but when we are talking about keratoconic patients, this kind of spherical equivalent is quite impressive, and these patients were extremely happy with the outcomes that they had. Almost 90% of patients had a CDV of 20/30 or better. A significant number of patients also gained lines of corrected distance visual acuity. As you do see, a number of keratoconic patients also have a high degree of axial myopia, and even in the normal population, they do. Yeah, I'm just winding up now. We also have patients with low versus high astigmatism. We did a subset analysis to see if patients with a higher degree of astigmatism, more than 4 diopters. So we had 68 patients which had more than 4 diopters of preoperative cylinder astigmatism to see if they had a difference, and there's no difference between the low and high astigmatism. Between ICL and IPCL itself, again, we had a large cohort of patients who also underwent IPCL, and the differences were quite similar. This is the most interesting slide where we looked at centered versus decentered cones. And over the later years, we started doing decentered cones also. And we had 34 eyes of decentered cone as well. And even in these decentered cones, as long as they had good spectacle corrected visual acuity, were adapted to their cones, these patients had excellent outcomes. And the patients, the decentered cohort did not have worse outcomes than ones with the central cone. So appropriate case selection, patients who are satisfied with their spectacle corrected visual acuity in these irregular corneas are important. sizing, you would keep into account the extremely high anterior chamber depth that you might get, falsely high ACD that you might measure in these patients. And of course, with all these in mind, you can give optimal results even in these patients. Thank you so much for your kind attention.
Thanks, Shreyash. You seem to have covered every single point. Dr. Praveen, would you take a question? Because all my questions have been answered in the talk.
No, I just wanted to appreciate Shreyas for the amazing study, especially the one on phakic IOLs and keratoconus. And yeah, I mean, it generally seems that they're not the first choice for most patients with keratoconus, because you would expect that contact lenses probably would do a much better job. But other than spectacle correction, is there anything else that you would do to assess suitability for these patients?
So initially, like I said, we were looking at whether the cones were centered or decentered. We were assuming that patients with a centered cone would probably have a better quality of vision. And we were strictly aligning only to centered cones. And it was only on a couple of occasions where the patient themselves with decentered cones on topography, but wanted to not wear spectacles. And also, like I mentioned, higher degrees of anisometropia, where one eye is very early KC, other eye is advanced KC, not very comfortable or not wanting to wear contact lenses, RGPs, and have 6.6 part, 6.9 spectacle corrected visual acuity. These were patients where we tried phakic IOLs in these decentered cones as well. And they also did extremely well. And that is when I felt that these patients, whatever be the degree of coma, probably some amount of the coma is translating into subjective cylinder as well. And they're accepting it as a cylinder, as an astigmatism. And as long as they are happy with the quality of vision which they have with spectacles, I think that's the single most important criteria for me at this point of time than the K-max or the central or decentered cone or the amount of high order aberrations.
I agree 100% with all that you say. Thanks a lot, Shreyash. Stay with us for the next two speakers.